part because she had tremendous difficulty taking pills. But in fact, when there was money for viral suppression, she found she could take the pills. And the financial incentives, I will say, and there are a few patients I should mention who we are really in a clearly transactional relationship. They show up every 2 months on the day they're due. They do not want to talk about their Hep C treatment or any other things. They want to get their labs and they want to get their money. I am okay with that, and I have seen a few patients transition from that transactional relationship to a more full primary care relationship, but there's certainly part of that. Now, I will say, whenever I talk about the Max Clinic, the incentives are something that a lot of people focus on because it is unusual and ask, well, how's that paid for and is that really sustainable? And is it right to compensate patients for something that they should do for their own health? And the answer to those questions are that we did pay for it with research funding at first, but we transitioned to state funding for this activity, so it is sustainable, at least for us here in Washington. And I, again, see the financial incentives as a way of helping patients make the decision to come to clinic an easier one. When people are thinking about where they're going to sleep tonight and how to get food, being able to give money can make medical care appointment much more worthwhile than the long-term conceptual to patients benefits. So, switching gears now, I'm sorry, that's not the right slide. I want to talk a bit about our efforts to have real-time data exchange. So, finding patients who are out of care is hard to do. I've described the challenges with using surveillance and clinic data. And one thing that we are hoping will be more effective is catching patients when they hit the system. So when they are booked in jail, when they come to the emergency room, and when they're admitted to the hospital, and when they come to the STD clinic. This requires real-time automated data exchanges. And one example of that from Louisiana, called the Lafitte Project, used surveillance data to match with hospital data and sent an alert to the first provider who opened the chart. So this was often someone in the emergency room, and it would tell that person, this is someone who's out of HIV care, give some suggestions of actions, and ask for a disposition. We have a similar system now between our surveillance data and with UW Medicine, but we instead have the alerts on the other side. So our care linkage team is alerted when somebody comes into the emergency room or is admitted who has unsuppressed viral load or has not had labs recently. We are in the process of creating a similar data exchange with the King County jails. And that's what the previous slide was addressing. So going back to thinking about where we find patients and to what degree the jail is an important partner to work with, we did an analysis last year where we matched HIV surveillance data with jail booking data and found that there were about 200 patients in 2014 who were booked at jail, and only half of them were virally suppressed at booking. Not surprisingly, they had worse viral outcomes than the general population of people living with HIV in King County. They didn't do much better in the year following. So that told us, yes, that the jail in fact sees about probably 10% of our out-of-care patients in King County, and we really do need to work with them. As well, I've mentioned many of the Max Clinic patients go in and out of jail, and our case managers now have weekly conferences to make sure that we are coordinating the in-jail and out-of-jail care. So to sum up this part of the talk, we've realized that we need a spectrum of interventions to successfully engage people with people living with HIV. Many people don't need any assistance at all, and that's important to remember. And others need the Max Clinic. And based on our Max Clinic experience, we realized we also needed another piece in between there. And that is that for patients, some patients don't have as intense needs and they don't need all the components of the Max Clinic, but they have trouble getting to the Madison Clinic for whatever reason. Some of these are patients who are virally suppressed, and some of them are those patients who just no-show to appointment after appointment. So we are care providers providing primary care at walk-in visits. And we'll see how that works. So now, enough about HIV. I would like to switch to talking about how these findings and this experience is relevant to the broader population of people living with multiple chronic diseases who have extensive and complicated barriers to care. So certainly, these high needs complex patients, as I will call as a shorthand, are not unique to HIV. And I do think this is well recognized in UW medicine and in our community. There are many efforts which are working to help those patients access care and help address their barriers to care. Some examples of them are the Harborview High Utilizer Case Management Team. So they work with the high utilizers of the emergency department and try to cut down emergency department visits. The Medicaid Transformation Demonstration Projects here in Washington also focus on assisting some of these patients with accessing the care system. And one that has gotten a lot of attention nationally is the Camden Coalition, which is in Camden, New Jersey, and that is focusing also on what they call the super utilizers and putting into place an intervention that tries to address their barriers and provide care. So I think the question here, again, we have a lot of support with getting patients into the system and supporting them in the current system. And what I am interested in us discussing is whether we can change the structure of care for those highest needs, marginalized and sick patients. And this is essentially shifting our focus in this part of the discussion from changing the patient's behavior to really changing the structure of care we're offering. So I will talk about what I see as the relevance of these findings and implications for healthcare delivery, medical training, and research. So we have a service mission, as I know you all know, to care for vulnerable and marginalized patients. And I think it's important to revisit this as we talk about it, because I am not sure that the efforts of the Max Clinic or similar efforts will save costs. The Camden Coalition study, or pardon me, intervention I told you about on the last slide, is doing a large randomized controlled trial. It is run by an economist, and the goal is decreased costs. The Max Clinic is very resource intensive. There is no way it is cost saving. I don't know whether it's cost effective, but I do think it's important to note it takes a lot of resources to effectively engage this population. I'm sorry. I'm not going along with my slides, so pardon me here. So I think I want to get to this one. Yes. So I think it may not be cost savings, and utilization, in fact, may increase if we're doing it right. Many of the Max Clinic patients hadn't been interacting with the healthcare system at all for years prior to coming in. And I think as we think about the outcomes and how we would judge an effort like this, it's really important to recognize that the quality indicators are going to be different from standard of care. We provide a lot of off-guidelines treatment plans and deferred healthcare maintenance. This is essentially harm reduction healthcare. And we also need to often deliver specialty care that we would prefer the patients do with specialists, but aren't successfully getting them there. Okay, so I would like to think a bit about what the metrics are and how we would identify the patients that we all can think of and know, these high needs complex patients, and how could we identify them and what would be the criteria? Well, hospital readmission within 30 days is certainly a major metric that is focused on by a lot of payers appropriately, and there are many efforts in the Department of Medicine to cut down the number of people who are readmitted within 30 days. Some key examples, one key example I'd like to highlight is the Harborview CHF team that was led by Ted Gibbons, and they put into place an intervention that coordinated inpatient and outpatient care, let patients come in as walk-ins, and essentially had the nurses act as case managers. This was for patients with CHF who were under 65. And that did cut the readmission rate in half. The high utilization, I mentioned the high utilization team, and right now they are primarily focused on, coordinating with the aftercare clinic and Pioneer Square for the purposes of getting patients into medical care. We could also focus on patients based on their key risk factors: drug use, homelessness, mental illness. And that, I think, is done well in many ways by the Pioneer Square Clinic and the clinic that exists at Needle Exchange. Another way we could do this is similar to how we did in MAX, to say viral suppression is the main goal. We're going to find the patients who are not suppressed. And I think we could do the same thing with other chronic diseases. I do want to stop at this point to just say I want to be humble in this presentation. I know there are many people doing things, and there may be efforts that I don't know anything about. So I would really invite you in the question and answer session to talk about some of those that I may not know about. So things like a diabetic foot infection in a patient with diabetes, is that indicative of someone who's really failing standard care? Things like admission for missed dialysis appointments to get dialysis in the hospital, is that an indicator of failure of traditional care? And we could do this by focusing on the disease or really focusing on the patient and creating one clinic for the highest needs patients. One big challenge with this, I think it is worth saying that in HIV, part of why we are able to do the efforts that I've described is we have surveillance data. We can enumerate the entire population, and we can judge our health outcomes based on surveillance. We have dedicated resources in HIV that I recognize are much greater than patients without HIV, and it is important to say that. Hepatitis C is in a similar situation. We have surveillance data, we can identify individuals, we can help get them into treatment. But I think we would need to rely on referrals and, an EMR much more without surveillance for the chronic conditions. Okay, now I'd like to switch a bit to talking about my thoughts on the implications of our Max Clinic experience in particular for the training of medical students and other healthcare providers. So I think some key things that truthfully the Max providers, we learned as we went, often in consultation. We're treating substance use disorders, particularly opioid use disorders, providing buprenorphine and coordinating with the buprenorphine team, OBOT team at Harborview. One thing that I had never done before but had to learn about was starting antipsychotics, how to treat meth psychosis and other psychotic disorders, what to start, how to titrate it, and when to switch to long-acting. That is not something I ever had experience with in my training, and neither did Meena Ramchandani or Matt Golden, my colleagues in the Max Clinic. Hepatitis C treatment is much simpler with direct-acting antiretrovirals, with the direct-acting medications, where we have much higher cure rates, and it's much simpler for patients to take a daily medication. That is something that can be easily integrated if the provider is trained into other care settings. And doctors, as doctors, we need more familiarity with what the case managers already know, which is how things work in the jail, how they work in other community resources, and how to coordinate with them. So what are the implications for research? Well, I've described how our data to care stepped wedge randomized controlled trial really let us know that something that seemed intuitive and we thought was effective, in fact was not, and we needed to substantially reorient our resources. So we know control groups are important, but I just want us to think about that as well in health services research, where it is often common to do pre-post outcomes. We need more rigorous evaluation for a lot of these interventions. And methods can be used, operational research methods, that allow evaluation without individual level RCTs. These include things like stepped wedge cluster randomization, historical controls, time series analysis, and adaptive intervention trial designs. So in summary, what I've talked about today and how our program at the Madison Clinic and Public Health Seattle-King County has worked. So from 2012 to 2015, we were really looking to set out and find out of care people living with HIV and facilitate re-engagement with their medical providers. But that was not effective. In the last couple of years, we've shifted our approach to really focus on the core, high needs, complex patients and provide an alternate model of care. Our historical control analysis suggests that there is a large effect size, but certainly that has some limitations. And I'm very interested in your thoughts about how these findings are relevant to other high-needs complex patients, and interested to learn more about ongoing efforts around UW medicine. So I'd like to close with sincere thanks to the Fialkos, the Fialko Scholar Award Committee, and the Department of Medicine. Thank you very much.